Thank you again. It's my pleasure to introduce to all of you LaVarne Burton, who is the President and Chief Executive Officer of the American Kidney Fund, a national nonprofit organization whose mission is to fight kidney disease through direct financial support to patients in need, health education, and prevention outreach. Ms. Burton has led AKF since 2005. As the number of living people with kidney disease has grown, so has the need for the programs and services of the American Kidney Fund. And with that, I am proud and privileged to introduce to all of you LaVarne Burton.
Good afternoon. Thank you, Bill. And thanks so much to Gary for your leadership and for giving me the opportunity to address this crowd. I've been here for a number of years, but there's some energy in the room today. As I sat and listened to the last set of presentations, there's an energy, and I think it has a lot to do with this focus around partnership, because none of us can do this alone. The tasks are awesome, but together we can have many, many victories. And so I just want to applaud the National Minority Equality Forum for leadership on this. I want to identify myself with one other organization before I begin, because I think that is also very important to the partner and to looking at the challenges that we face from a comprehensive perspective. For this year, I am the chair of the National Health Council, which brings together all of the nonprofit organizations that deal with various disease states to allow us to work across the board on behalf of people who have various chronic diseases. Now, let me tell you a little bit about the American Kidney Fund. The American Kidney Fund, I like to think of us as having, really a very simple mission. The first part of our mission is to provide support to people who are in kidney failure to help them get the health care that they need. We also recognize the importance of increasing awareness and of empowering people with some tools that they can do to help them prevent kidney disease. I'm moving this. I'm not sure whether I'm pointing it. I got it. Okay. The great challenge of kidney disease really is the fact that it is so prevalent. Some 31 million people have some stage of kidney disease, and very many of them do not even know about that. A good part of our challenge is to make sure that people know about this disease and understand what it means for them. I like to think of it, however, in terms of each individual who's affected, not just the numbers. And you see on your screen a young man named Eric Dolby, who's from Raleigh, North Carolina. We honored Eric this past fall as our hero of hope. Eric is a nurse. When he was diagnosed with kidney disease, he was so devastated and lost so much that he became homeless. We were able to help him get back on his feet. But the story of Eric is a story of so many people dealing with kidney disease as well as other chronic diseases. Eric has a family history of kidney disease, of high blood pressure, and he was unable to successfully tackle that. It's the Erics of the world who already know about their history or who need to know about that history that we all need to reach and help them address these diseases before they're in kidney failure. Eric is a hero for us because after he was able to successfully deal with his illnesses, and he is on dialysis, he has returned to the community and provides so much assistance to people by working with the homeless. When you think of kidney disease, one of the first things that you need to recognize is that it develops over many, many years and in stages, going everywhere from mild kidney malfunction up to stage 5, which is kidney failure. I think the call to action, particularly for not only African Americans, but Latinos as well, is that when you look at those early stages of kidney disease, African Americans and many other minorities are no more affected than any other group. The incidence, the prevalence is about the same. However, when you begin to look at the latter stages of kidney disease, we see dramatic differences. African Americans are 4 times more likely than whites to end up with kidney failure. Hispanics are 1.5 times. Some folks have said that kidney disease is perhaps the worst disparity just because of that incidence in terms of chronic diseases, and that's really what we want to address. Looking at the population for this country, about 13% African American in the general population, but almost 1/3 of those who are in kidney failure are African American. And there are certain reasons that, and this conference has focused on those very well, in terms of why there are these disparities. The reasons come in terms of quality of care, access to care, as well as genetics, and I want to spend just a few minutes talking about those things. When you look at income, when you look at insurance state, there's clear evidence that not having sufficient income, as we would all gather, not having health insurance coverage, that there is a higher incidence of kidney failure. We need very much to encourage early identification, early treatment, because when this disease is diagnosed and aggressively treated early on, in many cases, kidney failure can indeed be prevented. I know we've got an issue on time, so I'm going to run through some of these very quickly. But we know that if you're not receiving the kind of preventive care and primary care that you need on an ongoing basis, that your issues are not going to be diagnosed, and you're not going to get to the kind of specialty care that you need to address issues with your kidneys. We also know that late referral very often occurs among blacks. It very often occurs with people who do not have health insurance. Not having that early care means that you may not get the opportunity to learn your options and to work aggressively to bring this disease under control. Therefore, you end up in kidney failure. We also know that there are some genetic issues, and there's more and more research talking about some of these genetic issues. For African Americans who have high blood pressure, for example, we know that bringing the blood pressure under control very often requires much more aggressive approach and much earlier approach, and we know that that's not happening. We also know that there's been some research to show that there are some gene links in terms that are prevalent among African Americans that help to explain some of the cases of kidney failure that are non-diabetic cases, those that may be caused by high blood pressure, for example. Having that link explained hopefully will lead to new therapies to treat people whose kidney disease may be caused by high blood pressure. We at the American Kidney Fund are enormously proud that one of the researchers doing that work at Johns Hopkins in conjunction with the National Institutes of Health began her early work with a grant from the American Kidney Fund through our clinical scientists and nephrology program. In addition to those programs that focus on research, the American Kidney Fund is also very much partnering with organizations around the country to help us give people like Eric who are affected by this disease immediate tools that they can use to do something about it. 2 years ago, we introduced a strategy called Pair Up, Join the Fight to Prevent Kidney Disease. The Pair Up theme is obvious in the sense that there are 2 kidneys, and so we focus on that. We also, in this campaign, specifically target women because of their roles in providing health care and providing health management for their families. And we ask them to, first of all, get tested, find out their own status with regard to their health, and then spread the word to loved ones and to friends so that they can better understand. The strategy has 3 components: education, action, and advocacy, and I want to talk a little bit about all 3 of those. First of all, education. We have been working throughout the country going to different cities and working with local governments, with social organizations, and other membership organizations in those communities to get those local governments to focus on the risk of kidney disease, to focus on the link between kidney disease, high blood pressure, diabetes, and indeed the subject that we were just talking about, obesity. This year we will be in a number of cities, about 18 cities. Last year we were in about 22, and we will sponsor Kidney Action Days. You can come to our website and get information about those to see if we are in your community and just to get general information about the risk of kidney disease. At those sessions, we bring in local organizations to help us increase awareness about kidney disease, to do screening, and to help people who may need to be referred to a health professional for follow-up, to give them some sources to which they can go to get that follow-up. We also have any number of educational materials that are available through the American Kidney Fund, through our website, that will help. And we have a helpline where people can call to talk about this disease generally, or to talk about specific issues that they have or that their family members may have. I'm having some problems moving it. Okay, moved a little bit too fast. Okay. We have the Kidney Action Days across the country, and we have called upon our patients as well as local officials to help us in getting out that word. And you see a picture here of an event that we had last fall in Houston, Texas, and we will be doing that again this coming fall. Okay. We also depend very much on partnerships with a variety of groups. In this picture, you see an event that we had where we called upon many of those partners, ranging from Dr. Rogers at the National Institute of Diabetes and Digestive and Kidney Diseases to Alpha Kappa Alpha sorority, and we had also our spokesperson at that point, Layla Ali, who joined us in New York, in fact, on Broadway, to highlight this disease and the importance of increasing awareness around the disease. And you see many of our partners, and we do not have any close in on with regard to our partners. We welcome anyone in this room, individually or in terms of your organization, to join us. And you can find information about how to do that again on our website. And we also have people outside from the American Kidney Fund who can provide additional information about what we're doing. We also look to provide training for professional education, particularly for primary care physicians, for primary care providers. Because the key to early detection, obviously, is getting people before they have seen the specialist. And so our courses, and there are 7 running online now, they are certified for continuous education credits of various kinds, and they are free. We work very, very hard in terms of also connecting to members of Congress. I certainly want to point out Congresswoman Donna Christensen, who's right here in front of me, who has just been absolutely wonderful in terms of the support that she's given us and given this entire community to help us highlight this issue. We have a patient advocacy network that now is about 1,500 patients strong. Because as much as I want to talk about this and draw attention to these issues, there's nobody who can be more effective than those who are directly affected. And so we've been able to mobilize patients across this country. We bring them to Washington to talk with members of Congress. We have them talk with members of the press, as well as talk with state officials about how their lives are affected by kidney disease. And finally, you see a list of the major Kidney Action Day events that we will have. These will be day-long events in the 7 cities that are shown there. If you're near these cities, please join us. In addition to our screening, our education, we also focus on nutrition, on fitness activities, and try to make it a day that's both educational and entertaining for the entire family. And would love to have you, as well as your organizations, to partner with us around these activities. Here's information on how you can contact us. Again, I want to very much thank Gary and Bill and all of the planners of this conference, and to thank all of you for taking the time to focus very importantly on all of these issues of disparities around chronic diseases and particularly kidney disease. Okay. Thank you.
I want to thank LaVarne for that presentation. She is running really a great and super organization that's doing tremendous work. There's not a, or maybe there's a lot of times when I want to pursue an idea, and one of the things I've come to recognize is that the idea can only go as far as the help of others that you can get. And the next person I want to introduce you to is someone that I've been developing a really close and personal relationship with, who is helping us to do something I think incredibly profound. I think you heard from Dr. Givens this morning about the capacity of big data, about the capacity to network, about the transformative ways that will help the minority community. So a couple of years ago, we began thinking about creating a national clinical trial network. And the idea behind the network was to link minority-serving hospitals and minority-serving physicians. So if you think again about those 2,500 zip codes, so in those 2,500 zip codes are 500 hospitals that serve the minority community. There are about 40,000 physicians who provide care, primary care, to those, to minority communities. And yes, that's part of our two-tier healthcare system, that minority populations go to minority-serving hospitals and physician groups. Those practices have been outside the clinical enterprise system of research and knowledge and innovation. They've been dealing with a lot of stress in the way in which they get reimbursed and that sort of thing. So I went knocking on the door over at Farmer. Didn't know him before we knocked on the door, and had a chance to meet Salvador Alisi. And we began talking about building a national backbone here that would allow us to accelerate the recruitment of minorities into clinical trials and to make clinical trials more diverse in this country. Part of the reason, at least in my mind, was not just the fact that we needed good science and information about this population, but the facts on the ground are, by 2020, 40% of the US population is going to be minority. By 2035, right, we're going to get close on 50% of the American population is going to be minority. I say this to my industry partners all the time: this is your new consumer base. This is what it's going to look like. And so I went to Salvador and said, so here's what we'd like to do. And he had some experiences in Scotland, and I'm sure he'll tell you a little bit about it, and how they were essentially building their research network in Scotland and getting people in Scotland to participate in clinical trials. And so we've come together, joined with Microsoft, and they'll talk a little bit about this work later on themselves, to begin building a national clinical trial network to accelerate the recruitment of diverse populations in clinical trials. I think this is transformative because now we're going to start getting the science that we need so that we can bring the innovations into the minority community. So Salvador Alisi, he's a physician and a scientist who has spent nearly a decade working for the National Institute of Health and recently transitioned into working for the biopharma industry. He is Vice President of Scientific Affairs at Pharma, and he'll be speaking to you today about the importance of clinical trials to the overall health of our nation. Salvador Elise.
And good afternoon, everybody. It's really a pleasure and a privilege to be here in front of such a diverse audience. Such an important time for the health of our nation. I guess we all recognize that no progress is possible in advancing healthcare without the development of new and innovative medicine. Efforts that are driven by thousands of passionate scientists, researchers across our nation and across the globe. A recent report from Tufts University stated that, on average, development of one innovative medicine from concept to the market takes about $1.2 billion. According to other reports, the number is much higher. According to others, it's a little bit smaller. One important core piece of the development of this medicine is clinical development. It's the evaluation of novel potential therapies in populations to make sure they are safe and effective. Clinical trials today, on average, take, again, according to the same report, 45 to 75% of that investment it takes to bring a new molecule to the patient. Our industry is proud to be part of this ecosystem, and I think I want to stress that we are part of that ecosystem. It is a complex ecosystem that involves a number of stakeholders. And as somebody else pointed out before me, the importance of dynamic collaborations. Collaborations with the government regulators, collaboration with physicians, collaboration with healthcare professionals, collaboration with the patient association. This has always been key, but there are even more these days where resources are becoming more constrained and everything seems to be a bigger challenges. We always think about clinical trials as advancing patient health, but they have much broader benefit. They allow scientists locally to engage in cutting-edge science. They bring benefit to the communities in a number of ways. If you just look at Virginia, for example, just for proximity purpose, between 1999 and today, our members have conducted about 3,400 clinical trials. Half of these trials have focused on the most devastating disease, chronic disease for our country, cardiovascular disease, cerebrovascular disease, and as we are going to hear in a moment, diabetes. Progress has been made over these years, and again, these efforts have not just brought healthier life to the communities. They've created jobs. They've created opportunities for funding of research. However, I think one element that we tend to forget very often is that none of this development, none of the clinical development would be possible without really patient participations. Patients are participants. They are really the true hero in this ecosystem. That means the patient, that means their advocates, that means their communities. Gary mentioned before my experience with Scotland. I had traveled to Scotland because of my previous research when I was in the pharmaceutical industry. We were launching a big collaboration between the government of Scotland, the four major universities, around how to launch translational research that could both help the population in Scotland, advancing disease, diagnosis and treatment, as well as in help academia and the industry doing drug development in a more efficient way. But beyond that point, one thing that struck me a lot, and that's how we started the conversation with Gary, is that when you're in Scotland and you see your physician, it doesn't matter where you are located. You can be in the smallest possible village, near Aberdeen or in the best academic center in Edinburgh. Your physician is going to have the same information in a way that protect the privacy of the patient and confidentiality using a network. And that's one important element. The second element is routinely your physician talks to you about clinical trials and clinical research. That's almost part of your annual check. Should not be the exception. Should almost be like the gold standard. Of course, there are differences that relates to both, cultural differences, size of country, and others. But I think I found that, quite frankly, very interesting and inspiring. Unfortunately, what we realize here is that we are really facing still huge challenges when it comes to building awareness among patients about the importance of clinical trials, the importance of participations in clinical trials, their value, as well as in recruiting and retaining patients in clinical trials, in particular among certain communities. Now, biopharmaceutical companies have certainly invested very heavily in a strategy to enhance participation to clinical trial. I guess I don't need to convince you about this, just if you look at the list of companies that are supporting these events, that tells you how important this issue is for us. We recognize that every day a clinical trial is delayed. That means a missed opportunity for a subject to get access to a new medicine that in some cases can be a life-saving medicine. And we feel we can afford that. That's part of our mission. At the same time, I would say we realize, like for some other elements of the clinical trial ecosystem, that this is a battle that we cannot win alone. And in particular, we think it is important, like in other aspects of what we do, to partner in a way that is constructive, effective with other organizations. So it doesn't come to surprise to you that Gary and I sat and had very, very fruitful conversation on this topic. And I was very excited to see that last February these talks translate into the announcement of a very important initiative, of a very important partnership between the National Minority Equality Forum and Microsoft. The National Clinical Trial Network, it's a public-private partnership that truly aims at improving awareness, leading to improve retention and participation by a diverse community to clinical trial. I was proud to be part of the initial conversation with Gary. Pharma was proud to be part of the announcement, applauding the goal of this partnership, which again aims at creating that awareness, that connectivity that should eventually translate into a more diverse participation. We strongly feel again that that's the approach to follow, that partnering, sharing the same goal, sharing the same approach, it is absolutely essential. So I really want to commend Gary for his persistence, including persistence with me, and kind of in his talk, but in particular for his vision and for his leadership. I truly look forward to continue my interaction with Gary and his organization to shape up this initiative into a successful effort. Thank you.
when I was growing up, my father used to tell me a word to the wise was sufficient. So in those 2,500 zip codes, we're going to be building clinical research centers of excellence. I'm sorry, in the 4,000 zip codes. That's our goal, to really get a clinical enterprise system built in minority communities. And I just want to add one little point to what Salvador said. It's also good business. I mean, you know, people don't sort of appreciate enough what that sort of infrastructure in the minority community can mean in terms of jobs and economic development and all of that. Now I have a great pleasure to introduce Enrique Conterno. He's a senior vice president at Eli Lilly and president of Lilly Diabetes. Diabetes is just a huge problem in the minority community. I say these numbers all the time because I want to be repetitive about them because they're important. 50% of everyone with diabetes in the United States goes to the hospital or the emergency room every year. 50%. You cannot have a healthcare system with 50% of the people living with diabetes being treated in emergency rooms and hospitals. In the minority community, it's somewhere between 55 and 60%, depending on which community you're looking at. Those are absolutely absurd numbers. I mean, those are, you got to say, that's absurd. And so we've had a great honor. In fact, the first diabetes index that we ever produced was supported by Eli Lilly. This was before we started mapping. It was one of those deals where we'd walk around and say, yes, we can map, we can bring diabetes down to the zip code, we could do it. And then finally, Tom Wallace at Eli Lilly said, prove it. I mean, you talk a good game, prove it. And they pulled together an advisory board with ADA and a bunch of other organizations to look at the product. And that's really what launched our career in terms of mapping disease. So we've always had a special relationship with Eli Lilly, and I'm really pleased to invite to come up. Enrique Conterno.
Thank you, Gary. Gary, thank you for your kind words, and thanks to the National Minority Equality Forum and other organizations present today who work to improve outcomes in healthcare. Please know your leadership is needed and it's crucial. I'd like to begin today by asking you to think for a moment about life expectancy. Specifically, let's think of the life expectancy for a man, and let's suppose that this man lives here right in Washington, just a few minutes from this hotel. Based on US Census data, this man might expect to live to be about 72 and a half years old, which, by the way, is not very good. The national average for male life expectancy right now is over 76 years. Now, if you get on a metro and go to Fairfax County or Montgomery County, the figure goes up to over 81 years. And that's good. In fact, it places these two counties amongst the highest when it comes to male life expectancy in this country. This means that in the time that it takes to ride a commuter train for about 45 minutes, we can see a change in life expectancy of 8 to 9 years. In other words, nearly a decade in the time that it takes maybe to read a newspaper or to catch up in some emails in the train. So what's the reason for such dramatic disparity? Is it related to race, environmental factors, access to medical resources, individual habits? The answer is yes, yes to all of the above. We all understand that there's no single reason for healthcare disparities. Likewise, there can be no single solution to address them. Our approach to improving this situation must be multifaceted. And nowhere is this more true than in diabetes care. Most of us have seen the statistics when it comes to diabetes. We're really in the midst of a diabetes epidemic globally. We know now that more than 371 million people have diabetes, and that the numbers are rising in every nation every year. Here in the United States alone, nearly 26 million people have diabetes. Now, the point I'd like to make today even though diabetes poses a problem of enormous scale, it's also a very personal disease. No two people with diabetes think about or experience their disease in the same way. And so just as unique circumstances can create different health risks for an individual living in downtown Washington or out in the suburbs, likewise, we must look at the uniqueness in each individual as we work towards improved outcomes in diabetes. That's what we're also trying to do at Lilly, and I believe in our industry. For our company, there's no group of people with whom we have a deeper history than those impacted by diabetes. As we look to reduce and manage the risk of diabetes, we have to try to balance both the macro and the micro elements. And we study diabetes at population-based levels, but the ultimate goal is solutions that are meaningful to individuals. In short, we try to think globally and act locally, or to be more precise, think globally and act with the individual in mind. Let me share a few examples of how we are working to establish this balance between the micro and the macro. Clearly, as a pharmaceutical company, one of the biggest contributions that we can make towards stemming the diabetes epidemic is to make the best possible medicines. To that end, we're expanding our portfolio to include newer diabetes medicines, newer classes, including newer insulins, new type of delivery devices. We believe that this portfolio approach is necessary to support the world's large, growing, and diverse population of people with diabetes. Importantly, as we develop new medicines, we work to ensure we have an adequate representation within our clinical trials. Lilly has added 350 diverse sites across our therapeutic areas just in the last 4 years. Within the US, we define a diverse clinical site as one where the patient population is more than 25% non-Caucasian. Ultimately, however, the standard we're working towards is one in which our clinical trial populations have to match the patient populations that we're trying to serve for a given disease as closely as possible. As you are very much aware, the prevalence of diabetes among African Americans, Hispanics, and other minority groups is significantly higher than for Caucasians. We have made meaningful progress towards having clinical trials populations that reflect these higher prevalence rates, but our journey clearly is not complete. Given the industry-wide need to accelerate recruitment and diversity for clinical trials, I was very pleased to learn about the initiative between the National Minority Quality Forum and Microsoft, and I agree with Gary and with Salvatore. This is not just a creative alliance, but it is truly a transformational effort and has the potential to achieve truly outstanding results. Now, when we talk about clinical trial diversity, it's important to keep in mind that racial and ethnic minorities are not the only underrepresented groups. this is very important. In diabetes care especially, we must also look at different age groups. I was just having a conversation before I entered to give this talk when somebody approached me once I let him know I worked in diabetes at Lilly, that there was a huge gap with some of the age groups. In particular, I want to talk about the elderly. As of 2010, more than 1 in 4 people in the US, age 65 and older, have diabetes. Those are very, very significant numbers. However, current treatment recommendations for older patients with type 2 diabetes are based mostly on evidence from healthier and younger populations. Only last week, a joint study by Duke University and the FDA noted that amongst trials listed in clinicaltrials.gov, fewer than 1% selectively enrolled patients aged 65 or older. Lilly has embarked on a journey to specifically examine diabetes care needs when it comes to older adults. And we believe that this project and initiatives could develop new treatment strategies that are different, both in terms of targets and treatment protocols from those most often used today. Now, we can even expand even further our definition of diversity to include people with a wide range of healthcare, social, and situational needs. And this can make sense as well. Here are 2 more examples that I'd like to share with you in a sense to try to broaden even our thinking even more. Both in the United States and globally, we are expanding our outreach and education for people with diabetes who fast during the Muslim holiday of Ramadan. Up to 1.5 billion people worldwide practice, for example, the Muslim faith. The numbers of people with diabetes are growing at alarming rates in many areas with large Muslim populations. Fasting during the holy month of Ramadan is an obligation for healthy adult Muslims. And some experts suggest that up to 50 million people worldwide with diabetes also observe the Ramadan fast. For many people with diabetes, and you will appreciate this, skipping or reducing meals can quickly result in very serious complications. Recognizing that many Muslims with diabetes wish to both fast and stay healthy, we're providing Ramadan-focused education materials both in the US and internationally. Here at home, we develop structured education tools to share with healthcare professional and religious leaders in 5 cities with large Muslim populations. Washington, D.C. is one of those cities. Staying on the topic of religious communities for a moment, Lilly has long recognized that churches and other faith-based groups are powerful allies for improving health. Our ongoing relationship with the Church of God in Christ, which has 6 million members, most of them African American, has had some excellent results. Several years ago, we started working with the church leaders to distribute educational materials focused mostly on healthy and active lifestyle choices. The leaders have asked many times for more copies of our brochures, and we have given over 1 million brochures and distributed those. Even more encouraging is that individual churches have taken the initiatives and now run, in fact, diabetes screening programs. Some have even revamped menus in their own church kitchens and created healthier meals. Some have applied for grants through the First Lady Michelle Obama's Let's Move program. These examples I have mentioned do not cover all we're doing to think globally and act on behalf of individuals. Through initiatives both large and small, our industry and Lilly, our partners, keep diversity in mind as we work to improve the lives of people affected by diabetes. I opened with a story about life expectancy And I'll close as well with a thought on the same topic. In 1900, the average American life expectancy was only 47 years. Hard to imagine. By 2000, it was 78 years. That's an increase of 66% in 1 century, which is truly unprecedented in human history. Now, a large portion of this improvement took place early in the 20th century, when major gains were made fighting infectious diseases and when insulin was first made available, in fact. Another big jump took place from the 1970s to the 1990s, as medical innovation took aim at cancer, heart disease, and AIDS. You might argue that given what healthcare was a century ago, changes and gains were easy to be made, and the future progress will be much more incremental. It's true that future progress against complex and difficult diseases like diabetes won't come easily. Nevertheless, we are today, I believe, in a position to close that gap. And that's a good place to be. As to just how we will close the gap, I believe the answer is right in front of us. It will come from a variety of interventions, including continued medical education, public policies, and collaborations that address people's needs at both the macro and the micro level. In short, closing the gap will have to be a multifaceted approach. And it will come from a variety of capabilities and imagination from people like you, exactly like you. That's why I'm so grateful to be here today, for us to take this challenge. Together, we are much stronger than any one of us alone. Together, we will make that progress. And together, we will close the gap and create better outcomes for people with diabetes. Thank you.
I first want to thank Enrique for his words and want him to know that we are expanding our work on the diabetes index. As I mentioned to you earlier, we're moving towards continuous community-based monitoring, moving towards a predictive stage and taking the index and looking at those 4,000 zip codes, as it were, and really predicting what's going to happen over the next 12 months in terms of people living with diabetes, going to the emergency room, going to the hospital, with the expectation that those numbers will be empowering because we'll know where the challenges lie and how we might move forward. I also have a little bit of a commercial and something that Congresswoman, she may have just left, we've been working on. It's a book called Diabetes in America. And what we've done is we have presented the statistics on diabetes for every congressional district in the United States. So you can go in there and we've ranked them so you can find out who's got the worst case and who's showing some improvement. This is something that we will be putting out every year because we think members of Congress ought to know what's happening to their constituents when it comes to this disease. This is ground-to-ground warfare here in terms of doing something about diabetes. I now have great pleasure. In fact, I ran into the hallway. We worked together a while ago, and it was good seeing him. Edward Martinez. He's chairman of the Institute for Diversity in Health Management. which is part of the American Hospital Association, and he's going to come and present our Booker T. Washington Award.
Thank you, Gary. I'm the chair of the Institute for Diversity and Health Management, and that's one of the affiliate organizations of the American Hospital Association. And our goal is to promote diversity in the C-suite and governance bodies of our healthcare organizations. We're going through kind of a visioning process right now, and we're going beyond just diversity for diversity's sake. And we're developing diversity with a purpose. And that purpose is the promotion and facilitating of health equity and improving the health status of our emerging populations. It is my distinct honor today to represent the American Hospital Association in presenting the 2013 Booker T. Washington Award to Dr. Bruce Siegel, President and CEO of the National Association of Public Hospitals and Health Systems, NAPH. Dr. Siegel is a physician, an organization executive, an academic, a researcher, and an advocate for our vulnerable communities. He exemplifies what is promising, innovative, and moral in the evolution of American healthcare. It is also a real pleasure to be with you here at the National Minority Equality Forum and to see Gary Puckrein again. We served some 10 years ago, on the National Advisory Panel that developed the first health disparities toolkit for collecting race, ethnicity, and language data. He has continued this absolutely critical work of generating and highlighting the data regarding the health status and healthcare needs of U.S. minority populations. And I really salute him. As recipient of the Booker T. Washington Award, Dr. Siegel is recognized as an individual who has made an outstanding contribution to promotion of wellness in emerging populations, the vulnerable communities of our nation. This award not only recognizes the change he has brought to NAPH, but also recognizes the scope and context of his career. As president and CEO of NAPH, he is putting the organization front and center in the pursuit of health equity. He is directing the organization to become a key driver of the Affordable Care Act, particularly as it affects our emerging populations. Eliminating disparities has become an organizational strategic objective for NAPH under his leadership, and he joins with NAPH members in the strong belief in the right of access to quality care for all and in safety net hospitals as the essential providers of healthcare services for the nation. As director of the Center for Healthcare Quality at George Washington University School of Public Health and Health Services, he headed the major initiatives of the Robert Wood Johnson Foundation, focusing on healthcare quality, public reporting, disparities, and the safety net. He also served as principal investigator on numerous related projects and studies funded by the Commonwealth Fund, the Agency for Healthcare Research and Quality, AHRQ, and the District of Columbia. What is apparent from Dr. Siegel's academic and research work in healthcare quality is that it has consistently included that aspect of quality that is overlooked in most quality work today, a focus on equity and the elimination of disparities. He is bringing this focus to his role as chair of the National Advisory Council for Healthcare Research and Quality. This is a council that provides advice and recommendation to AHRQ's director and to the HHS secretary on priorities for a national health services research agenda. In addition, Dr. Siegel serves on the boards of directors of the National Quality Forum and the National Center for Healthcare Leadership. He is also a key member of the American Hospital Association's own Equity of Care Committee that guides that organization's commitment to health equity. But as I think about Dr. Siegel's playing such a critical role in these advisory bodies, I am reminded that there was a time when these national bodies and committees lacked members of color who brought this diversity and a critical perspective to healthcare policy, research, and practice. But this is no longer the case. It cannot be said anymore by anyone, we just can't find them. It is with great pride that I ask you to join me in presenting the Booker T. Washington Award to Dr. Bruce Siegel of the National Association of Public Hospitals and Health Systems. Congratulations. It's quite heavy.
Thank you, Ed. That was quite the introduction. I hope maybe I can get a tape of this and play it for my kids, and maybe I'll be treated a little better back at home. I have two wonderful teenage daughters, but I'm not sure they think of me in exactly those terms. That's probably better. I also want to thank Gary and the National Minority Quality Forum for all the work that they have done over the years. I've had the opportunity to partner with them on really important work around these issues, especially when I was at George Washington University. And this is a very urgent and important things that need to continue. It's obvious that I'm thrilled to get this award. Don't think I deserve it. I'm amazed to get an award that is named for Booker T. Washington, who dedicated his life to equity and who set the stage for so many of the opportunities that we have come to enjoy today through the struggles of so many. We all know that fundamental changes are reshaping America's healthcare system, from the public's demands for higher quality and value to all the new requirements that are flowing out of the Affordable Care Act. But really even more profound are the changes to our nation in terms of its people. Racial and ethnic minorities, blacks, Latinos, so many other populations are now a third of the U.S., as you heard before, and will be a majority by 2042. Texas has already joined California, Hawaii, and New Mexico as a majority state. All of this makes our work all the more urgent. A truly high-performing health system must perform for everyone. A system that only delivers for some of us is a system that can never ensure the health and health care for all of us. Now, it doesn't have to be this way. Safety net hospitals have been leaders in closing these gaps. Every day, these essential hospitals are striving for excellence for all, including the most vulnerable. And the good news in all of this is that we're not alone. Our own association, as Ed started to mention, has joined with the American Hospital Association, the American College of Healthcare Executives, the Association of American Medical Colleges, and the Catholic Health Association in a national call to action to eliminate healthcare disparities. I ask for you to join with us in this as well. This initiative has three clear goals that we believe will drive better care for everyone. First, collecting race, ethnicity, and language data so we know who our patients are, and so we know that we are providing the highest quality of care to everyone who we touch or walks through our doors. Secondly, increasing cultural competence training for all clinicians, administrators, and support staff across the American healthcare settings. And third, and perhaps most difficult politically, increasing diversity in governance and management. So when we walk into the C-suite or the boardroom, we see faces who look like America and can make decisions on behalf of all of America. Now, addressing disparities is no longer just about morality or ethics and social justice, which are all incredibly important things. It is also now about across-the-board excellence. It needs to be embedded in the daily work of nurses, doctors, hospitals, the private sector, like you saw here earlier today, and so many others. And I think we have a long way to go, but I think we're actually finally on the path to getting there. The essential hospitals of NAPH, the Safety Net in America, looks forward to continuing this work with all of you. And I am proud to be a small part of that effort and to share this day with all of you as well. Thank you so very much.